These are my declarations. I've been involved with quite a few of the studies that I'll talk about. I have some commercial links, but they're not relevant to this talk. So Eric Smith wrote a nice review 3 years ago looking at vascular cognitive impairment trials. And you can see here on the top right early phase 2 studies, a large number of interventions, later slightly larger phase 2, and then in the middle some phase 3 studies. Suffice to say that none of these have delivered yet so far. One of the problems with studies up till now is that they've been too small, and you can see that in the lower panel on the right. If you think about vascular intervention trials in the realms of hypertension and hyperlipidemia, cardiology, more widely, stroke, they're involving thousands of patients, and these are hundreds usually. And of course, one of our problems is that any studies we do are going to be on top of blood pressure and lipid lowering, antithrombotic therapies, and if after stroke, reperfusion therapy. So some of these or all of these are going to be modulating the vascular cognitive effect as well, which makes our life somewhat more difficult. I want to talk or start with nitric oxide, molecule of the year in 1992, and of course leading on to the Nobel Prize.
Can I very briefly interrupt you? It's still showing as presenter mode.
Okay.
Right.
I think I'm going to, okay, I'm going to spend 30 seconds on this. And swap my screens around, and I think, because I can feel that this could go horribly wrong, I'll tell you what, I'm going to leave it as it was. Let's just try again. Is that any better?
Perfect.
Yes?
Thank you.
Perfect. Got the right way around. Okay, take two. So, this is the classic model for nitric oxide formation, really from the last century. L-arginine, an amino acid converted into nitric oxide in the endothelial cell, and we're talking here about vascular NO, not neuronal NO or inflammatory NO specifically. This endothelial-derived NO will then diffuse out rapidly into the smooth muscle cell, leading to relaxation, or into the lumen, where it has effects on platelets and leukocytes predominantly. And of course, it rapidly breaks down, a half-life of about 6 seconds, into nitrite and nitrate. So in the noughties, the first part of this century, we realized that this breakdown pathway from NO to nitrite to nitrate is in fact reversible through a very different mechanism. And this is particularly relevant to dietary nitrate intake. And in essence, food you eat is absorbed, the nitrate is then circulating, it's concentrated in salivary glands, and then released into saliva. Bacteria on the back of your tongue convert nitrate to nitrite, so that's reduction. That nitrite is then absorbed. It can also have effects in the stomach. The acidic environment will also reduce to nitric oxide. But of course, that nitrite can then go around the body and get converted to nitric oxide elsewhere. So very different formation of NO from the conventional pathway. So what kind of foods are dietary nitrates? Well, they're the kind of things that Granny told you to take to stop you getting Alzheimer's or vascular disease, or indeed some cancers. But things like beetroot and spinach and celery, radish, kale, and so on. Superfoods, many of them. Now, one of the problems with the vascular NO story is as we age, the amount of NO we produce from our endothelium declines. And this is even worse during acute events like myocardial infarction, or in this case here, ischemic stroke, and even more so in intracerebral hemorrhage, which allows us to develop the idea of actually, can we replace, as we get older, nitric oxide exogenously? So I want to bring in prostacyclin, our second key actor in this story, and really draw analogies between this pathway of nitrate sources, either organic drugs such as isosorbide mononitrate or glycerol trinitrate, or inorganic dietary nitrate, or of course dietary L-arginine, or indeed L-arginine that's made from other amino acids. That creates nitric oxide, acts or causes the second messenger cyclic GMP levels to go up, and that's the active compound. That is then broken down by phosphodiesterase 5, and you can prevent that breakdown with sildenafil or dipridamol. So they will, of course, raise cyclic GMP levels, or at least stop them breaking down. And you have a very similar pathway, not so much in terms of the input, but if you think about here, NO and prostacyclin, both vasodilators, antiplatelet agents, this time acting on cyclic AMP. Again, there's a breakdown moderated by phosphodiesterase 3 this time, and you can inhibit that breakdown with cilostazol. So if we're thinking about the vascular effects of nitric oxide and prostacyclin and what might be useful in preventing vascular dementia, there are, of course, the hemodynamic effects, lowering blood pressure. There are the antithrombotic, in particular the antiplatelet effects. Anti-inflammatory ones, particularly modulated through leukocytes. So this is the particulate part of the inflammatory cascade. And then something that's both new and not so new is that NO and probably prostacyclin may have antimicrobial effects too. And that's relevant in two ways. Of course, there's a long-standing history of atherosclerosis being related to chronic infections in the vessel wall, and more recently some evidence that dementias may be associated with bacterial invasion in the brain and toxins. So this is a cartoon that Joanna Wardlaw and I published 5 years ago, and it shows the main actors, the cellular ones, the endothelium, smooth muscle cells in larger vessels, pericytes in the very small ones, platelets, monocytes as representative of leukocytes. And then the soluble factors, of course, NO and prostacyclin. But here the drugs that we can use, like cilostazol or dipridamol, to try and modulate the system. So if we're going to do some work in this area, what evidence do we need? We need evidence of effects on surrogate measures, and I'll show you some of that. And then, of course, direct measures, including cognition and dementia. What are our target groups? Are these stroke patients, small vessel disease patients, other forms of vascular dementia, or indeed Alzheimer's disease? And then you have a variety of interventions here. The organic nitrates, classic drugs which have been with us for, well, GTN for more than 150 years. Inorganic dietary nitrate, and then these PDE inhibitors, dipridamol and cilostazol. So rather than showing you evidence that organic nitrates have effects, which many of you will know, I'll show you some somewhat newer data, or data that you may be unaware of, really picking on dietary nitrate and what effects it has on those kind of intermediate or surrogate markers. Most of this work is done with beetroot juice, not because there's anything special about beetroot juice per se, except it contains a lot of nitrate, but because you can drink it very easily, and you can get a placebo version, so you can, in other words, compare a fixed dose with a 0 dose of nitrate. And this slide just shows that a meta-analysis of a large number of blood pressure lowering trials, beetroot juice lowers blood pressure. Now, you might not think that 3.5 millimeters of mercury reduction is that much, but that's actually worth about 20% reduction in stroke at a population level. A couple of studies on antiplatelet function, reducing aggregation in response to ADP in collagen. Evidence for anti-inflammatory effects through cell interactions, so dietary nitrate reducing platelet monocyte conjugation. Increasingly, we realize that platelets are not just about thrombosis, but they're about inflammation as well. And then some interesting work on oral health. We're beginning to realize that dementia may be associated with invasion with bacteria and toxins from bacteria found in the oral cavity. And dietary nitrate may influence that, partly through salivary pH, which is increased, and therefore you get less caries and therefore less bacteria. But also because this potential that NO is bactericidal, particularly for the unpleasant sort of bacteria that we don't want. About cerebral blood flow, here's a study with beetroot juice with a small study in older people showing increase in frontal lobe white matter cerebral perfusion. Now, we've done many years ago studies looking at glycerol trinitrate on cerebral blood flow. This is the last century. This is using SPECT scan, hence the blurograms, evidence of a large cortical stroke with a perfusion defect. You lower the blood pressure by 10% with intravenous sodium nitroprusside. You do not see an increase in that perfusion defect. If anything, it's reduced. And in a similar story, using xenon CT scanning this time, and glycerol trinitrate as the NO donor, you can see here again a perfusion deficit in a left cortical infarct, and you give them a GTM patch, and about an hour and a half later that starts to fill in, and it's not just ischemic stroke, but it's also after hemorrhage. So we can see short-term effects on cerebral blood flow with these NO donors. Now, we've done a lot of trials. 5 trials are in this meta-analysis, involving a total of 4,000 patients with acute stroke or subacute stroke. And I just want to focus on these 3 panels here. 3 telephone markers of cognition, telephone MMSE, the TICS-M, and animal naming. And what this data suggested to us is that there's a very strong time-dependent effect. If you go out much beyond about 7 or 8 hours, you get no effect. But if you can go earlier, you see improvements in these 3 measures of cognition, and indeed in a load of other measures of the Rankin scale, disability, quality of life, and so on. So this suggested that early treatment was associated with better cognition. We have published more recently a large trial in the ambulance with treatment within 2 hours, and unfortunately it didn't support these data, but it did very much focus on this front end, and we're now wondering if there's a little bit of room for maneuver here. That's ongoing work. What about beetroot juice and cognition? Well, this is a small study in volunteers looking at one aspect of cognition and improvement, and also at the same time improvements in cerebral blood flow. Again, acute changes. Let's think about cilostazol. As I said, it's a PDE3 inhibitor, so it's acting in the prostacyclin pathway, used widely in the Far East for secondary stroke prophylaxis. And this is a meta-analysis led by Joanna Wardlaw, comparing trials of cilostazol versus control or aspirin or clopidogrel or both. And 2 main markers here or results: one, a reduction in ischemic stroke with cilostazol, and secondary, less intracranial bleeding. Now, the latter is expected. Cilostazol is a weak antiplatelet agent, and some of its effects for stroke prophylaxis will be through other mechanisms, including smooth muscle cells and vasodilation and so on. So in the context of this nitric oxide and the cilostazol story, we've reported, Joanna Wardlaw and myself and others reported a small study in patients with chronic lacuna stroke. The first one, LACI-1, was about short-term tolerability and feasibility, 57 patients. And the key things were that it was feasible to give these drugs over 8 weeks. And secondly, there was some evidence that cilostazol might be having beneficial effects in the brain. And here's some evidence on cerebrovascular reactivity. A more detailed paper on this is in development. But that led us to go on to the second LACI trial. And this again is a feasibility study, but now we're looking at long-term tolerability for a year and starting to get more interested in efficacy. Can we see reductions, improvements in cognition and so on. This is very much ongoing. There was a trial steering committee recently looking at 263 patients, very, very similar people to those in the LACI-1 study. And obviously the intentions here are to go on to do bigger studies either in lacuna stroke or maybe in all stroke with lacuna stroke embedded in it. And it's very pleasing to see that we're up to 270 patients today out of 400. So this makes it really a very large lacuna study. So work in progress, encouraging data so far, recruitment, intermediate markers, cognition, repurposing of old drugs, introduction of dietary nitrate as a modulator, again, cilostazol as a repurposed drug. There are some problems. Getting a beetroot study funded is a nightmare. There's simply disbelief by reviewers. How can this work? Well, there is biological plausibility and activity. And I'm pleased to say we are about to start a study, but not for this indication. And then there's a general reluctance by medics to prescribe these older drugs, particularly through side effects such as headache. And I do think we need to balance the risks of or the adverse events such as headache versus the potential to modulate and attenuate these dreadful diseases of dementia. So at that point, I will stop sharing, and I will, normally in a conference, I would invite you to come and have a drink with me afterwards, but instead I'm just going to have my beetroot juice and cheers. Thank you.